Welcome back, everyone. This is Rob Waters, Program Director with State HIT Connect. We've got a great session coming up now today, which is really one of our collaborative learning roundtables. So please do get your pencils nice and sharpened to submit some questions, introduce your own state experience to join with some of the other presenters for today's session. The topic for which, just to get things started, is exploring traditional, non-traditional approaches for Medicaid eligibility, redetermination. I'm sure a lot of folks on today's call are very familiar with what's happening. Our facilitator for today's call, Josh Schultz, Senior Policy Analyst with Softheon, will provide a little bit of a background on all of the policy and the systems perspectives there. Joining Josh will be Rebecca Hayman, also with Softheon. She's going to be helping out with facilitating the Q&A and keeping an eye for those questions coming in via the chat function. But of course, front and center for today are our two state representatives, Nonis Spinner, Director of Eligibility Office, Office of Medicaid Policy and Planning with Indiana FSSA, and also Alexander Quevedo joining us from, I hear, a very sunny Puerto Rico, who is the state HIT coordinator. So at this point, I'm going to pass you over to Josh, and he'll get the session started.
Yes, hi everyone. I'm Josh Schultz, Senior Policy Analyst with Softheon. Thank you for coming to today's session. I wanted to start with kind of a backdrop for the whole conversation today, which is the Medicaid enrollment growth that's occurred since March 2020, when the pandemic began. As of May 2021, the latest month where data are reported, Medicaid enrollment is up 11.5 million beneficiaries. And in that context, states have begun to prepare to unwind and come back to the Medicaid operations and processes that they had in place before the pandemic and before the Families First Coronavirus Response Act, FFCRA. In August of this year, CMS released guidance that gives states up to 12 months to return to their normal Medicaid eligibility processes once the PHE ends. States have to complete a new Medicaid redetermination in order to remove anybody from the Medicaid rolls during that time. This new guidance that CMS released is an increase in time that states have to return to normal operations from 6 months under the previous administration. Interestingly, even though states are given 12 months to return to normal operations, the FMAP increase from the FFCRA is going to expire much sooner than 12 months. It's going to expire under current law as soon as March 2022, if the PHE ends in January 2022. This change, or this discrepancy between the FMAP increase and the unwinding, will put pressure on states to act to redetermine all their enrollees in less than 12 months. Because of that, Congress realized the predicament states are in, and the recently released text of the Build Back Better Act includes provisions to phase out the FMAP increase more slowly, starting in April of 22. States would be limited to redetermining or processing changes in circumstances for a maximum of 1/12 of each of their Medicaid enrollees for each month for 6 months, from April 22 to September 22. So it really will slow down states, or it makes states slow down the process of redetermining. And it also requires states to contact enrollees before disenrolling them. With that context, I want to turn this over to Nonis Spinner from Indiana to talk about the unwinding plan for Medicaid there.
Thanks, Josh. So I have been in my current position since November of 2015, and it was always kind of a given that in any presentation the Office of Medicaid Policy and Planning gave, we would say 1 in 5 Hoosiers is covered by Indiana Medicaid. Since the PHE started, we have actually increased that to, we're a little over 28% now. of our population is covered by some form of Medicaid. So we're covering 1 in 4 of our Hoosiers. We have increased enrollment 34% since March 2020 when the PHE maintenance of effort requirements began in Indiana. Next slide, please. So I made sure on each of these slides to put current. I think that each iteration of additional information we've gotten from CMS, they've all been great and helpful, and definitely see the logic and the usefulness in them. But it does mean that you have to kind of readjust your plans when new things come out. So this is our current plan. When we learn of the PHE end date, we will send out an informational letter. It's not going to have a due date attached to it, but it will let individuals who are in danger of closure when the PHE ends know that they need to provide some updated information or they could face a negative eligibility action. Our managed care entities, our health plans will also be sending out postcards and following up on them with texts, phone calls, all of the extra things that they have the ability to do for our managed care population. They'll also be following up on return mail and reporting new addresses to the state to help support our eligibility staff. For our fee-for-service groups, the state will be sending these additional postcards. We've designed some really eye-catching postcards. We've, in previous notice campaigns, we have heard from consumers themselves that they pay more attention to a postcard than a letter. So we will be sending those out for our fee-for-service groups, mainly our age, blind, disabled. And we also have a statewide helpline that we call 211. They will be given copies of items that we'll send to members, and they'll have scripting to help anyone who might call them to ask questions about what it means. We may also be able to get them to help us with outbound calling for this group. Next slide, please. So we are going to prioritize groups for verification or negative action. First, we want to make sure that we clean up the rolls of those who are required in normal times to pay premiums so that we don't start billing them and then turn right around and close them. We feel like that would cause a lot of confusion, frustration, appeals. So that will be our first group that we send out. And then the second group is going to be children and any pregnant women who will not be pulled into our expanded 12-month postpartum coverage that starts in April of 2022. And then the last is going to be our age, blind, and disabled groups. They are traditionally most stable as far as their eligibility and also in many ways the most vulnerable. So we decided to make that our last group to prioritize. All of the actions and notices are going to be staggered as much as possible to reduce the volume that we'll have to follow up on at one time. As you know, any of you who are deep into eligibility for Medicaid or other SNAP or TANF, when you send notices out, you get appeals, you get calls, you get reapplications. So we've called this kind of in our state, this will be the restart of churn for good or ill. So we are going to try to not send all of the notifications at one time, but spread them out as much as possible. Next slide. So some specific things we're doing with our technology to support the unwind. We do have a special queue for mass change exceptions, which is where our system tried to take an automatic action, but for one reason or another, a technical error happened. We were not able to. So there will be a special queue for those so that they can be prioritized for our workers. We'll also have a special queue for documents who are returned by someone who was extended due to COVID rules. We are working to allow members to upload documents on our benefits portal. This is something we haven't had the support to do up until now, so really excited about that and hoping to have that in place by the time the PHE ends. One other thing that we put in place is upon a successful annual renewal, we are aligning the new renewal date for all members of a family who have identical household composition and income counted in the budget. So we found, we used to align our SNAP, TANF, and Medicaid redetermination dates, and after the ACA, we stopped doing that. So we do have scenarios where, let's say there's a family of 4, mom, dad, and 2 kids. Dad's redetermination or annual renewal may be due in April, and maybe mom's is due 2 months later, and then maybe kid 1's is due 2 months later, and kid 2 is 2 months later. So we have a lot of extra work when we're collecting all of the same information. And we have gotten not a few contacts from members saying, why do you keep making me do the same thing over and over again? So in this scenario, when dad provides all of the information needed for his annual renewal, we also have all of the information that we need to be able to do an ex parte renewal for everyone else who is in the same family, has the same assistance group composition, income counted. And so we will align the redetermination dates for all of those identical assistance groups. And we also had, in December 2020, we implemented our asset verification system. So this allows us to have an electronic source to use in determining if ex parte renewal is appropriate for our age, blind, and disabled groups. And I think that may be all I had.
Great. Next, I'll turn it over to Alexander.
Hi, good afternoon. So here in Puerto Rico, we went live on June with our eligibility system, but only for new applications. So since the pandemic, we have been renewing month by month all the applications so far. Also in June, we got to work with our poverty level, which made an increase of 12% of participants. So far, we're keeping those participants in the system until December. On December is when we are planning on starting sending notice for renewals that are going to start on January. Our local offices, regional offices, have been open since July, which means we're also attending people at this moment. So we have been managing our population participation, on a present basis and also online. On December, we're planning on putting into production the citizen portal, which means we're going to have a lot of participants that do not need to get an appointment. They can do it online, they can upload documents, they can do all this kind of stuff. And we're trying to make that automatic renewal process start on January, which means it will lower a lot our appointments or people that have to go to the office in order to be recertified for the process. Next slide. This is what we are doing different here in Puerto Rico. We are including the Medicaid enterprise system concept. So that means the eligibility system, the MMIS system, the health information exchange, and the enterprise data warehouse. Everything is falling under the Medicaid program, and all of these programs are within the Department of Health, which means the Secretary of Health of Puerto Rico has issued quite a few administrative orders in order for us to comply with quite a few of these things. We have a sister agency here in Puerto Rico, which manage the contract with the MCOs. We work closely with them in order for make changes to the contract process. With them, we are making sure that we have all the population that we need. We make the reports, we make in the meetings with CMS, we request them, the information of all the participants that we want to keep on the program. And I think the next slide is going to be able for me to explain this. So this is what we're doing different in Puerto Rico. Here in Puerto Rico, with our new eligibility system, we are connecting all the agencies that have the information for the certification or the new applicants. So instead of asking all the participants to bring information, we can actually make the renewals, just verifying the information directly with the agencies. We are connecting to the federal hub. The participant can upload information starting on January directly to the platform. When they are making a new certification process, they can include all their family members. We're going to make the system do the Magi and no Magi process automatically on the system. So we will make sure that we can include everybody. Depending on what happened in Congress this week, we're going to be able to continue keeping all those people that are in the system right now based on the poverty level increase that we made in Puerto Rico. And that's something that our medical director is working with CMS. I'm the technical guy, so I'm going to focus on this technical stuff. So this is what we're doing different. We have two different platforms. One that is using our caseworkers. They have, if people call or they go into the office, they can go into the system, and also providing an automatically form for the participants to be able to do it on their own. We have a call center. We are putting into place a tier approach. So there is a different type of issue. If it is something that the user cannot do, or is if something automatically that the system should be doing, we're going to be able to manage those calls in order to keep the process as seamless as possible. And we're working directly to CMS to probably start our certification process to the platform on June next year. And I think that's what I have.
Here we're going to move into some discussion and Q&A for folks, for both you, Nonis, and Alexander. Rebecca is collecting questions that are submitted by the audience. So please, while we go through these questions, please think of your own and submit them for the panelists. So the first question I have, and it's really for both of you, each of you to answer, is how have you used non-traditional data sources to inform your Medicaid eligibility and reassessment processes? And why don't you start, Nonis?
Okay, so we have had longstanding relationships. Some of the things that Alexander was pointing out, that they've built these communication methods. We've had a lot of those in place already. We have integrated eligibility, so SNAP, TANF, and Medicaid are all in the same system, and they share the same information. So the main new one that we have is our asset verification system. Like I said, we implemented that in December 2020. So we have, before that time, we had no electronic source to look for assets. So we think that is going to be a great help in not only program integrity, but also we hope that it will help our age blind and disabled population who may just have problems remembering what their assets are. Maybe it's some Christmas club account that they had 25 years ago and they haven't touched since then. So we're hoping that will also be helpful to that population so that it helps them verify things that otherwise they might have difficulty proving.
Great.
Yeah, on the same thing, we are connecting to our other agency of the government, just gathering information we think is important. Since, like I said, this is something new for Puerto Rico since May. So we're gathering a lot of information, making sure that we have a data warehouse that we're storing information, not only gathering for eligibility, but from the MMIS and also from the HIE. And the Medicaid program has access to start working with a lot of the population that they don't know that they may qualify for the system. And that's something that is on the pipeline for Medicaid to work on.
Great.
I'm going to jump in here, Josh, with a question.
Great.
So we have, which Medicaid reassessment provisions are most relevant to you in the Build Back Better Act?
So we are still analyzing all of the implications, but I think the certainty on the dates and the FMAP will be really helpful in planning. So that's something that we think is going to be a big help as we work with our budget agency, our legislators, just to make sure that we're all on the same page and the plan works for everyone. So that's the part that stuck out to me the most on initial reading of it.
Yeah, the same here. Here for us is the date when everything is going to change. That's what the Medicaid director is more interested in.
Awesome, thank you. And then we have one for Nonis. What are the implications in Indiana from the CMS August 2021 guidance around Medicaid unwinding?
So we did change our plans to be in compliance with the extra advance notification requirements. I know that some states had been the whole time sending out when someone failed, but we didn't close them. I know some states were sending you would normally fail eligibility, but because of the public health emergency, we're keeping you on. And the initial guidance had said if you did that within 6 months, you didn't need to send extra notification out. So our system never did that to start with, so it wasn't quite as much of a drastic change for us. We are trying just to make sure that we cover all of our bases based on that new guidance. We are going to give everyone 30 days to return verification and then additional adverse, at least 10 days notice of the effective date of any negative action. So we are making sure that we let people know as much as possible what's going on. But again, because we had not been able to send we would have closed you except for the PHE notice, it wasn't quite as big of a change for us.
Mm-hmm.
Any comments from you, Alex, from Puerto Rico?
No, I don't think we have that issue at this moment since we're just renewing everything. The only thing that we would different this month is that we went back to the previous table, everything that, before the poverty level was approved by CMS. So any new case, we're gonna be certified under the previous rule before the poverty level, unless we have anything changes on the Congress this week.
Understood. And now I think we have a question just talking more about specifics with numbers. Have either of your organizations estimated what proportion of individuals reassessed during unwinding will actually be terminated?
So we've looked at it a few different ways. Our system has been, so we're doing all of our regular eligibility work, but then when we get to the very last step of the authorization, if you fail, we're putting a special COVID code on you and keeping you going. You remain open. So for that entire population that has that code, we put them in a parallel environment and we run eligibility determination on them. So we do have a pretty good idea of how many are going to close. It looks like every time we have done this updated information, it looks like about half of our additional enrollment since the PHE started could be in danger of closure.
Another question that we have in the chat specifically for Alex, how is Puerto Rico planning to leverage your health information exchange related to redeterminations?
Oh, that's a good question. So basically, since we're not only capturing the Medicaid population, we're capturing the whole population of Puerto Rico, we can understand, the disabilities or necessities of the whole population and make an assessment on them and sending them information or notice like, hey, you might qualify for this or X services, not only Medicaid. Since we're working with other government agencies, we're going to be able to help them understand, hey, you haven't reached out to us, but we're reaching out to you. So that's what we're doing through the HIE.
Great. And are states thinking that the PHE will be extended beyond January, since there hasn't been any notice received 60 days in advance that it will end in January? Any thoughts on that?
I mean, we're kind of waiting until the 18th. That would be about the 60th day that we would get advance notice. I know we have asked CMS, can we have more than 60 days? And they were working on that, but I think we have kind of thought it may be April at this point, but really there's no way to know for sure. Maybe by November 18th, I'll have a better answer for you.
Well, I have one. How, under the BBB Act, states are going to be limited to reassessing only 1/12 of their Medicaid population per month. How are you going to respond to that limitation, Indiana? Nonis.
So currently our largest projected disenrollment group is about 1/20th of our total Medicaid population. And other than that, we did kind of take advantage of the PHE to even out some of our months for redetermination, because we had really heavy redetermination months in like January and February because of some different things, the ACA implementation and our Healthy Indiana Plan implementation dates. So we did spread things out a little bit where we're fairly even outside of the PHE. Everybody else, we're fairly even on distribution for annual renewals. So we're hoping that we'll be safe, but it's definitely something we're going to keep an eye on as we continue to plan.
Yes, as Noni was saying, the exercise that we did is like 1/20th for January. So I think we're keeping up the same pace.
Understood. And then we have another question here. How can states plan for the upcoming wave of reassessments? If you guys had to give maybe some tips or advice as to states exploring this opportunity, what kind of advice would you give them?
I keep going first, Alex, so why don't you go?
Well, since we're starting the program, it's something in Puerto Rico, people like technology, they like innovation. So I think just education and just going out and putting out there that, hey, you can do this on your own from your house. And it's the first time. You don't have to make an appointment. You don't have to leave your house. I think it's something that people will jump into just getting into the process.
I think for us, so again, Alex is more the technical guy, and I'm the eligibility person. So I think for us, having policy, operations, and the experts in the systems meet together frequently and have kind of brainstorming meetings, which we have done through this whole time. You know, no crazy ideas, throw it out there, maybe it'll work. So it's been really helpful that, especially our vendors, some of our long-term vendors have really creative ideas about how to do things, and they have a good understanding, a basic understanding of the policy. So putting together the staff the people that manage the staff that will do the work, and then the policy, and then those who are running the MMIS and the E&E has really, I think, brought us to the best plans that are possible.
Absolutely. And you just touched on vendors. Can you explore maybe a little deeper what relationships, if any, you have with these vendors providing the ancillary services related to Medicaid eligibility or reassessment? So what do those relationships look like with those vendors?
So our E&E, definitely, we rely on them heavily to be able to do all of the things that we ask them to do. We do have we use the AVS system, as I mentioned. We do use the Verify Current Income. We use the work number portion of parallel kind of thing for SNAP and TANF. Our other data matches were already in place, as I mentioned, but we will be relying heavily on our health plans, our managed care entities, to help us with outreach and with managing. We assume, you know, we've got some people who may have been on Medicaid for 2 years and not had to verify anything to us. We may have brand new people who've never been on Medicaid before, and one change we made was to accept client attestation at application. So we could have new people who have never had to verify, they've never had to send a pay stub before. So it's going to be very new for a lot of people, a lot of communication needed. So we will be relying on our call center staff that work for our operations arm within the state, and then also our health plans.
Any additional thoughts that you want to add, Alex?
Well, I think the same thing. You know, we have all the major vendors that are here in the Medicaid office. So we have our E&E, our HIE, and our MMIS vendor working side by side. So any change that we require, we just have a quick meeting. Hey guys, this is what we need to do. And so far, you know, we are very happy with all our vendors. Their compromise with Puerto Rico is beyond what I would expect.
I think one thing I would add, and maybe this is unique to Indiana. When this all started, we were scrambling. How do we keep these people from closing? So we asked our MMIS, if we send you a closure and you can see it's not for one of these allowed reasons, don't do what we asked, leave them open. And so that was kind of a safety backstop for us. But it's going to be really important when this is all done to do a recon of the systems so that we get back in sync and we match going forward, because right now, you know, it was just fast and furious, try to protect people. But after things calm down, we will need to make sure that everything is matching.
We also have another question in the chat. In terms of system enhancements, are there long-term benefits for E&E coming out of this planning process?
I'm thinking, because we had a meeting this morning and we're discussing with our E&E vendor. Actually, after this meeting, I have a meeting with them to discuss things that we have learned of the process and things that we know they're coming our way on January. And I believe they are a lot of stuff that we could do. And like Nonis say, I'm the IT guy, so I always throw these ideas that I think they might work, but I need the vendor, I need the business, I need the Medicaid program telling me, hey, yes, we can do this, we can do that. So I believe there is a lot of room for innovation based on what we have learned in Puerto Rico. And, you know, based on, and I have to make a parenthesis, just for example, we are on the top of the vaccination population. And that's something that we have to take into account, how we're getting all this information through the HIE, through our registry, immunization registry, and what else can we fed to the Medicaid program in order to make them access more people?
And I think for us, we have been able to do some things that, and not necessarily PHE related was the only permission, but they were things that we could have done the whole time, but as a state, we just never chose to do. So aligning the redetermination dates is something that's allowed through the CFR. When we verify everything we would need to do a redetermination, and it's essentially an ex parte for those individuals. I think it accelerated our plan to allow uploads of documentation, which is great. And that's actually a requirement, not an optional, but we were not there yet. We also, as I mentioned, during the PHE, we started doing self-attestation at application point. So it's giving us, and this is a broader point too, but specifically to the self-attestation at application, it's allowing us to see how it works. Is this something that we want to stop when the PHE ends, or do we want to keep doing it for some people or for all people? So we are sending, we approve based on the client attested information, and then our E&E goes in that night and finds those individuals who are marked client attestation for things we normally require documentation on. If they're not verified through some other way, electronic verification or something, then we'll automatically send a request for verification. When it comes back in, or when it reaches the due date, we're also tracking, okay, did these individuals verify everything we needed? Did they respond at all? And so we're going to be able to, but of course we still can't disenroll them until the end of the PHE, but it is giving us some hopefully really good data to help us make a determination when this is all said and done. Do we want to keep doing this? Did it turn out to be really risky and most people never responded to us again? Or did it turn out that in general, the things that they said ended up being true and they verified it and they kept on going? So those are some things that are exciting for us to try out and see if it works. I think that eliminating churn, which we've done during the PHE, there could be a lot of good data as far as what that means for eligibility, what it means for health outcomes, what it means for equity. So we are looking at some of these things as an opportunity to learn more for the future.
And are there any more E&E system changes planned, do you think, or is it too late at this point?
So for us, and Alex, I'm assuming it's the same for you, we, our new E&E, we did kind of a phased conversion from the legacy system, and we finished that in spring of 2020. And it's constant change. We are constantly updating things. There are something, it's a huge undertaking, and as much as we try not to miss anything, things get missed. So we're getting a little bit past the question in the first question in every meeting being, what did the other system do? What did we used to do? So there are some things that we'll just have to keep assessing and refining and improving. So it's really exciting because our new system just has a better capability to do so many things that our old system couldn't do, but the old system was familiar. So I think we do have a packed schedule of changes that keeps on rolling.
I agree completely with Nonis. That's the same thing we're doing right here. We have weekly meetings with change requests just to make sure what things are, okay, maybe the user was familiar doing that, but is that what we really want? So I completely agree with you.
Thank you both for your input on that. Now we have a few questions regarding technology. So one being, are you doing any mobile options in your technology right now?
Well, in our case, since we just went live, it is on the roadmap, but not at this point.
We currently have a benefits portal where you can apply online. You can report a change. That's where in the near future, you'll be able to upload a document, and it is completely mobile compliant. So we do have that capability. We don't have a special app, but our web pages are mobile compatible.
And how are you both addressing identity with electronic signatures of authorized representatives?
We're working on that. That's part of the enhancements that they will go live with our citizen portal on December. And since we are connecting to the federal hub, We're also working with other strategies since, like I said, the enterprise is looking at MMIS and HIE. We're trying to get a vendor that can do maybe just one single sign-on for everything, so we can gather that information, and that's something that we're working on.
Yeah, and unfortunately, we don't have a great way to do that yet, but it is a goal for the future to figure out a secure way to do that that is convenient, but also meets all the requirements and make sure that both parties are agreeing to it. Because we didn't have that in place when the PHE started, and it was very difficult for people to get physical documents and sign them and fax them or bring them in or mail them. We did institute a very low-tech solution where the potential authorized representative and the member get on a three-way call with one of our eligibility workers, and it's recorded that each of them agrees to each part of the agreement. But that's definitely not the most streamlined way to do it. So we are working on finding an electronic solution.
Great. And then we have another question that just came in. What testing schedule will you utilize in the run-up to the transition anticipated peak capacity?
I'm pretty sure our systems have started testing already in their parallel environments. Like I said, it's the same as all of the real eligibility information, but they can do things in there that don't affect the real case. So they are testing now, continuing to test, and I think that will be an ongoing process as we keep tweaking things.
Completely agree with Nonis. We're doing the same thing.
Great. Is there anything else you guys would like to share that you felt wasn't touched on in your previous slides as we're waiting for more questions that we haven't touched on yet?
Oh, I see Alex shaking his head no, so I'll go ahead. I feel like I'm dominating. I keep jumping in first. One thing I think when we were preparing for this, we were asked, what are the challenges? Kind of what scares you about this? And one thing that we are, and I think we'll solve it, but a technical challenge that we have our best and brightest minds working on is how do we turn off our special COVID code that keeps people from closing and keep those people from closing immediately before we've done all the things we need to do, but not continue to protect. Let's say after the PHE, someone new applies and they're approved, and then the next month they're over income. We wouldn't want to apply that COVID protection to them. So we are looking at how do we make a date-specific logic that takes this static population as of the PHE end and says, we're protecting you until we don't, but not continue to let new people be added to that protection group.
Alex, have you guys determined any workarounds, or are you guys in a similar boat?
Well, no, I think I should, emphasize that we work on the same office space. So right now our MMIS, our E&E people, they work together. So that's the reason we can tell, okay, this is what we're getting, this is what we need, this is how much money we're paying for the new population that we have in, and that's the money that we ask our Congress, and when we go upstate to Washington also and request money. So I think just having that synergy with the MMIS and the E&E system, they're working side by side, so they're not working on silos. So we have all that information together, and when we make a decision, it's a joint decision throughout all the system, and we have all the data available. And that's something that has been helpful here in Puerto Rico.
Understood. I know Josh has a few slides about Softheon's own Medicaid reassessment solution. But before we go there, I did get another question that came in. What sort of analytics are you running to discover equity outcomes from the process, and how is that being applied?
Well, we do have one of our vendors is the one in charge of doing our data mining, but I think the medical administration will be better answering that question. But I know we do have a team working on those.
And we have in-house in the Medicaid Policy and Planning Office, we do have an epidemiologist who helps with our data analysis. And She has taken the group that I would call the in danger group and done that kind of analysis on the race makeup, ethnicity makeup, to show the difference between the population that's in danger and our state as a whole. And it does show that the impact of closing these individuals on some accelerated schedule would definitely have a disproportionate impact on people of color in Indiana.
I've heard that that's the case nationally as well, or that being estimated to be the case potentially.
So Josh, no other questions on my end as of now. I don't know if you would like to jump into what Softheon does, and then maybe we can have a conversation around that.
Sure. So we have, at Softheon, we have an external Medicaid reassessment product that is based on our AVS, and it allows state workers to submit a list of enrollees with their name, social security number, and address. And it creates a risk score analysis for the members that are submitted. And it can score them as red, high risk, yellow, medium risk, green, low risk, to help eligibility workers prioritize the reassessments. This is useful to reducing workload and overhead for eligibility workers. We already do this in Indiana, working with Nonis, where we process renewals at the end of each month through the AVS system. And so that is our external Medicaid reassessment product. We also have AVS. We support the AVS in several states. And yeah, so it would be very interesting to kind of spend a brief moment or two talking about, you know, whether or not your folks have any plans for external vendors in the Medicaid reassessment process. Let's see. That's it.
And I think while we wait for questions in that regard, Nonis, can you maybe speak to your experience with us thus far in this space? I think that'd be very beneficial.
Sure. So the way that we set it up is, so we needed to do AVS several years ago, and we had not yet done it. And CMS kept politely informing us that we did need to do it. And so when we started speaking with Softheon, we knew that we could get a manual solution where there's a user interface. The user goes, they put in the information, and then they get an email saying it's ready, which is probably great. But we wanted to do all of it through data exchange, overnight files that didn't need the worker to do anything. So we did set it up so that, especially for redeterminations, I know renewals, we call them redeterminations. So hopefully that's not too confusing. The annual redetermination, 90 days before the redetermination date, we will ping the AVS and we wait to see if information comes back. When it comes back, our system looks at it to compare to the thresholds for the particular type of benefit that the individual is on. And if there's nothing that's not reasonably compatible with those thresholds, nothing looks like they've got $5,000 in their bank account when they're only allowed to have $3,000 or something of that nature, then we go ahead and put them into the rest of the redetermination flow, which will say, can we renew you ex parte? You don't have to do anything. We just send you a congratulations, you are approved for another 12 months. Do we need to send you a mailer that says, here's what we know about you, tell us if anything has changed? Because we have all the information, but it's kind of old. Or we have individuals that something is out of sync, it looks like you're over an asset limit. So we're going to send you a mailer that says, we really need to hear from you. You need to provide us this thing by this date. And if not, you could lose eligibility. So we never really had the ability to do that for our age blind disabled population before because we had no electronic source to ping against for assets. So that's going to be a big help to our workers, a big help to our population. And will also help program integrity and help make sure that we are directing our efforts at those who are truly eligible.
Great.
Thank you for that. We do have another question that just came in. It says, what are you doing to ensure the continuity of coverage for disenrolled beneficiaries, data sharing with benefits exchanges?
Alex, I don't know if you want to go first on that one.
Well, remember, like I said, I'm a tech guy, so there is a lot of questions that maybe the administration will be better prepared to answer them. So I believe we just extending the periods, we just having the conversation with CMS just to make sure that we won't let anyone, out of the system before it needs to be. And also with all the data we have program integrity working directly in another office right next to mine also. So we're just making sure that we have all the data so the administration can make the right decisions.
And with our current plan, no one will reach the point of disenrollment without having received at least 5 pieces of notification that this could be coming. And additionally, we'll be trying to do phone calls. So we hope that everyone will submit verification, even if they are over the income limit. That helps support the individuals we can transfer to the federal marketplace, because if they fail eligibility, but they complied with all of our requests, they automatically get transferred to the marketplace. If they don't comply, then we don't send them onto the marketplace. So we're hoping that even for those who end up not being eligible, they do send in their information so that we can ease that transition for them and automatically transfer them to the federal marketplace. We are just hoping that as many people who are eligible stay on. We don't want to introduce hoops that they need to jump through. We don't want to restart churn any more than it has to be. If you're eligible, we want you to stay eligible. And if you are not, we hope that we can transfer you, hand you off to the federal marketplace so that you can explore other options for coverage.
So I have one question. I'm sorry, Alex, were you going to say something there?
No, I'm just saying that sadly, Puerto Rico does not take part on the market at this point.
Well, for both of you, I have one additional question kind of inspired by Nonis's, which is, what are you all doing to make sure that individuals who lose their Medicaid coverage in the upcoming reassessments are able to find other sources of coverage, or at least to point them in the right direction? And I know, Nonis, you just kind of discussed about referring some individuals to the FFM, but are there other, outreach efforts or, other initiatives that are part of your planning for the unwind to help keep people covered, if Medicaid is no longer appropriate for them, then in other types of coverage?
Yeah, here what we're doing, I think part of the workflow of the system is gonna redirect them to other sources. It's gonna tell them, we probably hoping going live with the change of circumstances also on December, and say, hey, if something changed between the time you enter your information, something changed, you can upload that information, and we'll give you 90 days in order for you to make any, upload documentation or notify the Medicaid office. And so far, that's the only thing I have heard that we're doing.
Yeah, and we're looking at doing that too, similar to what happens when you have your annual renewal and you have 90 days to come back without filing a new application. We are looking at doing that for this population as well, to try and assist them. We don't really have, as far as like referring them to employer-sponsored coverage or other things, we don't really have anything on that. We are putting specific language on our notices, all of these notices that they're going to get, not the postcard, it's too small, but the larger notices will include, if at the end of the day you end up not being eligible, here's how you get to the federal marketplace. Keep your closure notice because you might need to provide it if you need a special enrollment period. Here is how you find a navigator in Indiana. Here is, our free legal services. So we are trying to make sure that we put resources on there so that they can hopefully connect with another kind of coverage.
Great. That's really great.
And Nonis, you just touched on other resources or services. So another question we had were, Are there other ancillary services states are implementing to help during this period?
That could be with a vendor of data services or any number of things.
Yeah, probably, but nothing is occurring to me right now.
Alex, maybe anything you can think of?
No, right now, no. You know, like I said, there are some initiatives that they may come to mind, like redirecting that information to our commissioner here, you know, the insurance commissioner here in Puerto Rico, so they can have access to everything that is out there, but nothing that is concrete right now.
Understood. And then just another question that came in. Can either state elaborate regarding the strategies for risk modeling for CMS risk-based approach?
Yeah, so the guidance that the updated guidance from last fall did say that states are allowed to prioritize and give a few suggestions on how you could do it, but said, you know, you can select your own option, but you'll need to put it in that verification plan that we may ask you for later. And so we did, the way that we prioritized ours was we don't want to start billing people for premiums and contributions when we're also in the process of closing them. That's going to be very confusing, very frustrating. So that's how we picked our first group. And that is our group that, you know, normally is able-bodied adults who have a little bit higher income, and then our separate CHIP program, which is also higher income individuals who may have more resources to find other coverage. And then second, for our children, it was kind of just the decision between do we have children come next, or do we use our age blind disabled population? And just internally in our state, we decided that hopefully the children will turn right back around and be eligible again, but we want to make sure that we leave until last our age blind disabled population, who probably will have the most difficulty in pulling together whatever they may need to come back into compliance.
Great. And as we have our last few minutes here, I just want to open it up to the speakers again today. You guys had anything that you wanted to touch upon before we close out this session?
Well, and I'm glad, thank you for inviting us. And I did have the conversation with the Medicaid director. And I think these communications are important, especially for us being a territory. And sometimes we think we're so different from the states, and having these conversations with other states, knowing that, hey, we're not alone doing this. It's just that we think, since we are here in the Caribbean, this island, it's good to have this communication open for us to understand how other states are doing what we think is so difficult, and you're having the same issues that we're having.
Yeah, and I would say thank you for inviting me as well. It's always fun, and I think every state is different, and every state's systems are different, but we have a lot in common too. Some of us use the same vendors. So anytime we can share ideas in a forum like this, we get ideas from each other on oh, I didn't think about that, or oh, that's a good idea. So it's really helpful. Sometimes it's just commiserating with each other that this is really tough, and we've had to work really hard. But we've helped a lot of people, help people keep their health coverage and help them have some stability. So just really appreciate the opportunity.
Thank you, as always, Nonis. Thank you both, Alexander. Great. Rebecca, we don't have any more questions, do we? No?
Not any questions at the moment, but I really liked what both of you touched upon by keeping those lines of communication open.
Yeah.
That's fabulous.
Well,
all right, Josh, I know we
everyone.
have, oh, I'm sorry.
Sure, no, I was just going to jump in. I thought you were wrapping up there, but
yeah.
Any additional comments from the group?
I know we have a final slide, the last one, Josh, if you maybe want to put it up on the screen. One of the best people to contact in Softheon's organization, I know we touched upon it briefly about our Medicaid reassessment solution, but we do have the contact information up there. Michael Sasko, he's a great guy to talk to more about potentially getting a demo if your state is interested in this process. So we just wanted to provide that information as well.
Great. Well, thank you, everyone.
Wonderful.
We're just about on time. Any other comments from you, Josh, before we wrap?
No, I just want to thank everyone for their time today. This was really a really great conversation. I really appreciated everyone's insights, and thought it was great. So thank you, and good luck with the end of the PHE and everything else that's coming up. So
We're in the eye of the storm.
Very much so, very much so. So we have, of course, a related session coming up for more of the, I guess, CMS sort of guidance on system-related issues. So please do stick around for that. Ed Dolly will be available. We'll be having a conversation between him and I, as well as taking questions from the audience. We do have some that were submitted by the registration form. Looking forward to receiving more, and we'll be discussing some of the planning related to the Great Unwinding, but of course, some of the alignment with some strategic issues as well. So looking forward to learning more. Thanks again, Softheon. We did put in a link in the chat here for folks who want to access Softheon's resource page at the State HIT Connect community website as well. So take a look there. We welcome your participation. Do sign up for your membership so you can complete your profile, access the member directory, and access all of the great resources that groups, including Softheon, as they're helping states plan for this critical transition period. But thanks to everyone for your participation, and we look forward, hopefully, for you to joining us again at 3 o'clock Eastern Time. Thank you.